1:20 p.m. Joe?
Here. Lord, in prayer. Dear most gracious Heavenly Father, thank you for today, and just thank you for the opportunity to serve our people. Guide and lead us, dear Lord, in our decision making today. And we just thank you for the wonderful weather, and we always thank you for our veterans, dear Lord. Guide and lead our nation. In Jesus' name we pray. Amen.
Amen.
Roll call. Sure.
Jeff Fulbright. Here. Dick Lay.
Here.
Jack Baker.
Here.
Carly Buzzard.
Here.
Joe Bird.
On him.
Julia Coates. Here. Jody Fishinghawk. John Garvin. China Glory Jordan.
Here.
Frankie Hargis.
Present.
Lee Keener.
On him.
Curtis Snell.
Here.
Janice Taylor. Here. David Thornton. Victoria Vesquez. Honey. David Walkenstick. Eric Allen Watts. Honey. We do have a quorum.
Thank you. The chair entertains a motion for approval of the minutes.
Make a motion to be approved.
Second. All in favor of the minutes, let be known by saying aye.
Aye.
Any opposed? The minutes stand. Yes.
I'd like to make a motion to amend the agenda under new business, number 1, a resolution approving and authorizing the submittal of a request to the Indian Health Services to participate in the 2014 IHS Joint Venture Construction Program Agreement for construction and operation of the Talcott Hospital. And I would put that in the form of a motion to amend the agenda to include that.
Do we have a second? All those in favor of amending the agenda, let it be known by saying aye.
Aye.
Any opposed? Okay.
We will have copies available in just a few minutes.
All righty. First, we'll go right into reports from Claremore. Welcome, sir.
Good afternoon.
Good afternoon.
Mr. Valyers sent me today again. He's on his way to Oklahoma City to area office, so I apologize he's not here. So again, you're stuck with me. But no, he sent out his report. I don't have too many comments on it, except I want to make a couple highlights for this group. This morning we have new employee orientation, and for the first time in a long time, we actually have three new physicians in that orientation this morning, 2 ER docs and 1 internal medicine hospitalist doc. So very excited that we're getting some docs in, and all 3 of these are paybacks, and they're residency trained, and I think they're all 3 going to be really, really good doctors. So excited about that. Another piece I wanted to bring up is at the end of this month, we will have a 24/7 pharmacy department. So at the end of August, we will have a pharmacist on site all through the day and all through the night, 7 days a week. So I think that adds a lot of good patient care, and it increases patient safety in our ER and then in our inpatient wards, especially in the overnight hours. So excited about those 2 pieces. And with that, I would entertain any questions from the board.
Yes, Councilor Watt.
Thank you, Madam Chairwoman. So I noticed on the report that our CHS money for the Cherokee Nation comparison is no longer there, and I think it's because of what Brett's reporting in the Cherokee Nation report, that the transition's been made.
Mm-hmm.
So I guess you no longer have insight into our numbers. Is that why they're gone?
That's correct.
Okay. And the report says that the MRI is good, it's functional, and that you're picking up the last month or 2 of referrals, and everything seems to be going well with that.
Correct. Yep.
What is our approximate average capacity per day, or
8 patients per day. So right now we're only 8 hours, and it's about an hour per test.
Okay.
And we're looking to hopefully expand that in the near future.
Expand it in terms of hours?
Hour-wise, yeah.
Okay, because that's only 5 days a week too.
Correct.
Probably, is that
Correct.
Right? So I don't even know with 1 MRI machine that we could meet the need, but what is that need typically out of Claremore facility?
That's a good question. You know, before we got the machine, looking back 6 months, we had 500 and some odd referrals for MRIs.
Over 6 months is what you said?
Yeah,
Okay.
so there's a big need there. 8 a day,
That's not,
not a
yeah.
whole lot. So we're definitely going to need to expand that, whether that's longer days or we're looking at Saturday, Sundays. Kind of looking at those options.
Okay. So, because what is the cost savings, I guess, then for us not referring that out?
I don't know if Brett has a better cost estimate on what we actually pay for MRI. Brett, do you have any?
Yeah, roughly about 850.
850. I thought it was close to 1,000, so it's.
Yeah, Medicare rate's about 850.
So that's our, do we base it like on a Medicare rate, or is that a contractual rate negotiated? And so IHS would have one rate and we would have one rate because they'd be negotiated separately, or is that?
We're both going to refer out the same, to basically the same rate. We might go to like an outpatient clinic, say there's one in Tulsa that does just imaging. Sometimes it can be cheaper, but Medicare rate is all roughly 850.
Okay. So now IHS, I can understand why that would be cost savings internally, and we put that in. So if it's a Cherokee Nation citizen, then, because that's outpatient only, not inpatient, we compacted, right? So we would reimburse the Claremore Indian Hospital budget?
Direct service.
It's now direct service. I just want to make sure I'm clear. Okay, very good. Okay.
We appreciate it.
Yeah, I'm sure you do.
Okay. Want to make sure my mind was clear, so.
Yeah, they bill insurance and whatnot for patients. We have a credit card.
Thank you. And then the marshal service, we're still on doing once a day drive-bys, and security issues are working, and
I don't know how often they drive by, but I know we have a very good working relationship and they're very responsive.
very good.
So we appreciate
And then
that.
I saw a number of job openings in the report, and I'm really glad to hear your verbal report about the folks starting today.
Yeah.
But somebody had sent me a note and said that they went on usajobs.gov and it was something like 27 openings. And I'm not saying we're not facing the same issues. I mean, this is healthcare, period.
Sure.
So what does that put us at in terms of technical medical staff, like providers? How many are we short now?
Let's see. Probably still need about 8 docs total
Okay, across the facility.
across the facility. You look at family practice, ER, and IM, internal medicine.
Very good, thank you. You've been
welcome.
very helpful. Thanks, Madam Chair.
Thank you. Councilor Thornton?
Yes, heard that you had 500 referrals for the past 6 months. How many of those referrals are all of them Cherokee?
I believe we spoke about that at a different meeting, but it was about between 60 and 70% for Cherokee.
60 to 70%? You don't
Yep.
have any.
No. So 350 of those were probably Cherokee patients.
Thank you.
I have a comment.
Yes, go right ahead.
Yes, if 60% are about our Cherokees, how come the other tribes aren't stepping up and helping out with this issue if we've had this problem with MRIs for years?
Don't know that I can answer that question, but it's point taken.
Yeah, because we still got close to 40, maybe 50% out there. We got, what, 17 tribes that are represented there at
Yeah,
Claremore?
correct, 17.
And this has been an issue for quite a while, has it not? Okay, just thought I'd throw that out there. Thank you, Madam Chair.
Speaker Jordan?
By my calculations, that means we've got about an average of 83 a month in referrals for MRIs in the past 6 months. And if you're doing 8 a day, that's 40 a week, that's 160 a month on the average.
Right.
So we can go back and pick up, you can do the month's worth of, say, if it's on the average 83, you can do the month's worth, and then you can go back and pick up for the remaining half of the month, the backlog. So in about 6 months, would you guess you could be caught up?
Possibly. I mean, it's kind of half and half. Like you said, we can do half the new ones and half the remaining ones in a month's time. So we don't have any problem keeping up with the new business. It's going back and making sure we pick those
You've
up
got the backlog.
if they're still there. And a lot of those, I think, were picked up by CHS through the Cherokee Nation. So that number is much smaller than it was.
So maybe the backlog, say the 350 Cherokees were picked up, 150 is
Yeah.
all your backlog of other tribes.
Correct.
You can pick that up in about, within probably a month.
Or two, yeah.
You can have that caught up.
Yeah.
And be up and running and be ahead of the ballgame.
That's our goal.
That's your plan?
Yep.
Okay.
That may,
Go ahead.
the only reason we were looking at longer hours or Saturday, Sunday was making sure access to care. You know, everyone can't come 8 to 5 Monday through Friday. So
And I know that on those types of tests, I think we operate 7 days and in the evenings.
yeah,
So that's a good option for your working constituent.
Yeah.
Or your working patient.
absolutely.
Another thing that you said, and I'd like to compare where we are, I think we're 16 docks down across the, I think, we talked about that a few minutes ago, Dick and I did, about being 16 docks down across our health system. So in comparison, you're, what'd you say, 8 docks down at the one facility. That's just the health picture right now, isn't it? There's not enough doctors to go around, not enough nurses to go around. Everyone's trying to get out of the same pot.
Say enough good doctors to go around.
It's true. That's true in any field, isn't it?
Right.
We all want to hire the best,
Trying not to just fill holes. We're trying to fill holes with quality docs.
and
So,
that's the same way across our health system. I see Dr. Montgomery back there and nodding his head. We want to get good doctors, not just doctors. We want to get good nurses, not just nurses. And you're in that same
absolutely.
field. So when folks are upset, they need to understand this is not unique to just the Cherokee Nation system. I guess that's the point I'm trying to make.
Yeah.
This is the same thing happening, not just with our system, with the federal system. It's happening all across the country.
That's a good point.
We just need to recommend all our young people go into health because we're all living longer.
That's what I was saying. These 3 docs we just got were all paybacks. So that system can work, and that's how we get these new young docs. So they're real bright and hard workers, and hopefully we can keep them in our system.
But you only have them for 3-year payback.
3 or 4 years, and that's why we're saying hopefully at the end of 4 years they want to stay, but
And we'll be trying to steal them.
probably. You probably will.
I mean, that's the reality of the situation. Everybody goes trolling for watching
Yeah.
everybody else's.
I mean, if you don't steal them, the
backyard.
creeks will steal them, and then, you know, we're all competitors, but we're all on the same team, so it's a unique
But it
situation.
sounds like we're all kind of in the same boat trying to find these.
Yep.
And I know we've been creative. I think our program now has a deal with OSU to bring in some more young folks. I mean, that's the only way you can get them now to come to the rural areas is grow your own.
Yep.
And so we're getting real creative, and that's how eventually we'll reduce down the number of folks that we're short on. Appreciate it. Thank you for your comments.
Counselor Keener, you're next.
Thank you, Madam Chair. I guess still continuing the doctor question.
Yeah.
The 3 new hires are paybacks, and then you said mentioned that Mr. Valier was going to the area office. Does the area office, are they open to contract doctors more or less, or they're neutral on that?
I'd say for the most part they're neutral. I mean, obviously
Okay.
we want to have our own docs, but we'll do locums and contracts when needed, but ultimately we'd like to have our own staff.
Do you know what the ratio is now?
Don't know off the top of my head, but we probably have 5 or 6 locum doctors there currently. So compared to however many other federal doctors we have, and I don't know that off the top of my head, so it's fairly low.
And they're the good doctors too, right?
Federal ones?
Well, in
Or
the I was meaning the contract.
Well, and that's probably why we always like to have our federal staff or our in-house staff. You know, locums can be good. Typically, they're not as invested as your own staff is. They might be just traveling through and putting in their time. So,
Yeah, I didn't mean anything about the
No.
permanent ones.
yeah,
Okay.
you
They're all
get some good ones and some bad ones, just like anything else. But yeah,
At least with the contract doctors, you can find out and then do something about that?
Doesn't take long to find out, and you can usually do something about it pretty quick. Yeah.
And then my next question was on the pharmacy.
Yeah.
You think we can tell people September 1? Is it,
I think that's a safe bet, yeah.
Okay. And on the 24/7, is that open to walk-in people or just for the?
So what it's going to do is that right now our staff's there till 7 p.m. From 7 p.m. now to 7 a.m. when the next day starts, we'll have a pharmacist there all night, and they'll be taking care of the ER patients as well as the inpatient load. So they will be available. I don't know if we want to advertise it,
Right.
because this can be one of them after 7. So definitely if they're there for the ER.
I know I'll get that question.
Yeah, yeah.
Okay.
Let's see how it goes.
Okay.
Start with, and then we'll.
Yeah, I won't advertise it.
Okay. Thanks.
Thank you. Thank you, Madam Chair.
Anything else? All right, thank you for that
Thank
good
you.
report. Next, we'll have Ms. Connie Davis, Cherokee Nation Health Services, to give her report. We're sorry to see that she's broken an ankle, but she's able to come to work anyway, so.
Oh, it's almost
you.
over with. Thank you. A lot of good things to report this month. And we'll start with the volumes that our staff have seen. Wilma P. Mankiller saw 9,373 patients in the month of June. Redbird Smith, 9,648. Salina saw 7,875. Jay, 6,694. Nowata, 4,236. Muskogee, 13,559. Bartlesville, 1,970. Bonita, 6,134. Gaudougie Clinic, 370. And Hastings Hospital saw 28,222. And as a kind of a cumulative report through June, we've seen an overall increase in patient visits of 11.5% in that amount of time. And in our revenue collections, we have really done a good job in billing and collecting on our third-party revenues. And through June, I'm happy to report that so far we are $7.3 million over our budget from last year's collections. So our staff are really to be commended for working so diligently on that. And I think another statistic that will show you what adding the space to our much-needed clinics is Bonita. Obviously, they have their new center, and we see record numbers there every month. They've increased their collections by 286%. So just imagine how well we're going to do when we get Oshaleta open and we get new rooms at J and can allow better access to our patient. Three Rivers has increased by 41.73%, and Cherokee Nation Hastings has increased by 7.65%. So that's a lot of work, and that's how we can see more patients is generating this much needed revenue. We have moved staff into the newly remodeled Redbird Smith Health Center, and just a reminder that this Wednesday at 2 o'clock is our soft grand opening for that new facility. I can't wait for you guys to see it. It's absolutely beautiful. And then hopefully we'll follow probably October or November with an opening of the entire facility with the annex add-on. We have initiated the Crown program and the dental program, so we'll monitor that closely, and Dr. Jones will keep us apprised on how well that's being utilized and received in the health centers. Emergency room and urgent care treated at Hastings 5,673 patients in June. Our left without being seen rate was 7.1% in the emergency room and 6.5% in the urgent care. And we've had some big hiccups there just because of the sheer volume. We've got a very active work group there to address that. We don't want anybody leaving without being seen. And We're going to add 2 additional staff physicians to be able to see more patients, and a lot of those positions in the urgent care are filled by what we call PRN providers, and they work in our other clinics, and so they come in and they work a few hours, and a lot of them don't want to stay the whole shift. So we've got a very active group, like I said, working on improving those numbers, and I think we have a very good weekend this weekend that shows that those implementation of those services has had an impact. We did 414 surgical cases in the month of June. I don't know if everyone is aware, but Dr. B.J. Boyd, who's been the director of our behavioral health program for several years, has made a decision to step down from that position. And he will stay on staff as a clinician, thank God, because he's a great clinician. I think a lot of Dr. Boyd. But we went in and we've implemented a new scheduling process. We had over 500 patients on our behavioral health wait list, which is alarming to anyone in this room. But we've implemented some new procedures, and we're down in a matter of 3 weeks to only 200 patients on that wait list. We are aggressively addressing that and having a good success with it.
I think Counselor Jordan has a question.
Connie, in the next couple of months, can you all give us a summary of toe in, toe out on emergency room and urgent care?
We will try very hard. Most of that has to be extracted manually. And so when you're looking at almost 6,000 charts to get that data, it's going to be pretty cumbersome. But I'll see what we can do to try to monitor that.
That's
We've
why
done
I'm
it
saying
before.
over the next couple of months, and then if we can start watching that and see if we bring that down a little bit. I think the 2 doctors, are we talking 4 between 1 and 8?
I believe the model,
We've
I have to
got 4
defer.
between 1 and 8 now in urgent care. Are we talking about moving up to 6, or are we talking about just keeping 4 after 8 o'clock?
There, Brian, you may have to help me on your staffing model.
Our goal is to have 6 providers every day in urgent care. They stagger in, starting with 3, 8 in the morning. So we start off well, then 2 more come in, and 2 more come in, and so that we have 6 for the busiest part of the day, 2 leave at 8 o'clock, 2 leave at 10 o'clock, and then 2 are there till midnight to close out. And the idea is that, if needed, if we're really busy, then no one leaves, none of the providers leave until they close out.
Another thing that Brian has implemented is to put an administrator on call every weekend, someone in key leadership. And that way, sometimes you get so busy trying to see patients and keep up, no one even thinks, call someone else to get us some help, someone that's not having to put their hands on a patient. And so that was implemented this weekend, and then those people can start sounding alarms whenever people are waiting over 2 hours, because we know what our goals are.
And then the triage between the emergency and the urgent care, are we going to be able to address? It seems like maybe some don't need to be triaged over to urgent care, that they need to be kept in emergency.
Sandy Taggart is working on educating all the registered nurses that do triage on how to do a good triage, because we've identified some failures, and I think it's just time for some re-education. And
well, the first thing is we identify our failures, and then we can improve upon them. It's an evolving process. And every time I go to the hospital, which I go every 3 months, or, well, sometimes more often than that, I can see improvements. Every time I go, I see something that's being done a little different and being done a little bit better. And I know that you've got the time down on just going into the regular clinical system. The toe in, toe out time. I mean, I know from personal experience, on good days, I can be in and out of there in just about an hour. And that's going to lab, that's going to pharmacy, and that's going to the doctor. And I couldn't even do that when I used to drive to Muskogee. Years ago, when I'd go to the doctor, I'd end up waiting 2 hours over there in a doctor's office. And I kept thinking, I like my doctor back here, I want to come back here. And I've never regretted returning here 20 years ago or whatever. But we could we need to start watching our toe in, toe out on our urgent care for sure. And emergency, I haven't experienced that recently, but I know that we can get that time down. I really think we can, and a better utilization of our new rooms.
Absolutely.
Putting our folks in the new rooms and allowing the doctors to travel from room to room instead of calling them as they get ready for them. I know these are things that we've all discussed, and I know you guys are doing a lot of improvement on them, and I appreciate what you're doing.
Well, that's what we're here to do, and we're happy to address that. And you kind of alluded to a good thing, or not a good thing, but an issue. We have over 2,000 employees in the health department. And my assumption is the overwhelming majority of those 2,000 employees that show up every day, they want to do a good job. They want patients treated fairly. But unfortunately, there are those, handful in the system, that create big problems for others. And we are ready to address those as well, because that's not what I want for my family. It's not what I want for your family. So we'll take care of it.
And we're edging up just a tad on our, for those of you all that don't know what tad is, that's just a little bit. We're edging up just a small amount on our people leaving without being served. I think those numbers are coming up just a little bit. And
yes, they have.
We want to address why they left.
And that's something we want to integrate into the ER and urgent care provider compensation. You know, when you guys gave them the raise 2 years ago, and we said we wanted some performance issues based for their bonuses. And we've done these contract styles before, and length of stay and left without being seen. You're a little more motivated to see somebody if you think you're going to get hit in the pocketbook.
And of course, if you go to other hospitals, though, we're finding that their rate of leaving is going up a little bit.
Yes.
So it's not a unique thing to us, but it's something that we want to be the first to address and not be the last to address. And I know y'all are looking at that too. So I appreciate what you're doing.
Thank you.
Councilor White?
Thank you, Madam Chair. On behavioral health at Claremore, what do those numbers look like? Because we have consistently got complaints. I think we've raised them to you in the past. I mean, I don't even know if we know who's on the wait list because they feel so turned away and frustrated. So where is Claremore at specifically?
I couldn't tell you by clinic right now, just off the cuff, what those are, but I'd be happy to get that information and bring it to you either by email or by the next health committee.
Would you by email?
Sure.
Okay. The other questions I had was, I've asked for the PACE audit, and it hasn't been provided to me, and I understand that you want me to FOIA, but I'm so tired of it. That's a public document, so I'm a little bit frustrated why that's not just already provided to the whole council on the audit part.
I believe that is a CMS, that was the direction I was given, that it had to come in the form of a FOIA.
Because basically, that's going to tie up my time. I'm going to write a FOIA, and then you're going to tell me under this new law that it's a publicly available document, but it's not on the CMS website. So I'll be in one of those loops again where I'm not getting information on something I oversee. That would be my take on it. So I don't know if Elizabeth.
It's not publicly available right now. It's my understanding that that's still an open audit. And so it's not closed yet to where there's a final report that can be made public.
Okay, so what I'm, FOIA or GRA would be whatever we've got in terms of documentation today. That's not part of,
Because
okay.
there have been reports that were allowed to view at PACE,
Okay.
but not released out.
And last month we talked about, I know Connie wasn't here, but, so where are we at on the structure and stuff for PACE?
They're working on their policies. They have adopted some of Cherokee Nation's policies. We're working on their internal policies to give them the best policies they can have as far as hiring, firing, all that kind of thing. The board adopted some of Cherokee Nation's policies at the last board meeting. We're working through all of that. We're just working with the board and trying to, she's on the board, trying to work through this, the whole process, figuring out how they're going to fall on all of them.
So Because I'm confused, I guess, about where we were at as a tribal government with governance, whether we have governance and responsibilities for PACE or not. I know there's what I originally thought the MOU, MOA looked like, what I thought PACE was supposed to do, and then there's the feedback I get is much different from the actual users of the system. So is this something like in a couple of months we can go over and have a full explanation and explain to this body where we're at, what it looks like and how it functions? Or
now, there's a legislative act. It created it as an agency of the Cherokee Nation. It is an agency under the executive branch. That hasn't changed. So that is where it falls at this point. It has a board that looks at their governance and, you know, things like their policies and things like that, but it is part of it.
Okay.
There was a three-way agreement because they had to have that in place for their funding that basically said that Cherokee Nation backs them. That's the only agreement. They did have some MOUs on how they're different things. We're working through all of that. That's part of the process as we're working through how this is structured, but
okay.
It is under the executive.
Okay. So, thank you very much. That was my PACE questions. Couple of things. I want to thank you and your team and Brett Hayes for the CHS takeover at CIHS. So contract health service takeover at Claremore Indian Hospital for those portions, outpatient and such for the certain counties. And then on the $100 million or whatever the total is, I know you have the status report that we got on our desk for the build out. So which ones are we pursuing IHS joint ventures for?
The Hastings project.
And that will be it?
Well, because as I understand it, that we just received notice from IHS that the opportunity for that joint venture came out, and if you have broken ground, literally, on any project, then it disqualifies you from any consideration, unfortunately.
Yeah, that was some of the questions we were trying to ask early, because
they sent a pretty detailed list out. I think we received that about, just over a week ago, and that was why there was a sense of urgency to get a resolution. We have to have a resolution from the council to pursue that, and we have to have it turned in by September 12th, and the next council meeting was, I believe, the 15th, so.
Okay, well, I appreciate that. Thank you very much, Connie.
Counselor Lai, you're next.
Yeah, thank you, Madam Chairman. Electronic health records.
Yes. We are,
Yet?
well, we will be there, hopefully go live in April, I believe, of 2015. That's our goal. We've sent several staff members to Kansas City for intense training and development of what these things are going to look like, and we've got department-specific people, leadership represented so that it's done exactly the way they wanted, including physicians. I hear that it's going incredibly well, and it'll do even more than they had dreamed of in a lot of instances. The vendor also has been here, and they're almost constantly on site working on this. It's a big project, as you can imagine, but it's going very well. We still need our health IT staff fully up and running, and we're working on that.
Is that going to help some of these issues that the speaker was talking about?
Yes, it will. We will be able to probably report to you anything you really want to know as far as those kinds of turnaround times. How long does it take to get lab done? Radiology resulted. Lots of things that we know internally we need to know to fix access.
It's not only going to help you with information, but speed up getting an appointment, I hope, and those types of issues.
Yes.
The dialysis center in Salisaw, is it going good?
I haven't heard anything detrimental other than it is going very well.
And forgive me for asking again, the PACE, so Cherokee Nation owns PACE. We own PACE, is that correct? And so last time we were here, we didn't know for sure. You were working through the issues. Were some of those issues those MOUs or MOAs or?
There were some MOAs that were put in place back when it was started. having to do with like HR and things like that. It is the legislation, created an agency of the Cherokee Nation. It is under the Cherokee Nation. There's no question who owns it and where it falls.
Well, last time you couldn't tell me that.
We are, well, yeah, you asked about whether they should go, their complaints and stuff should go through like Hastings and
No,
all that.
I asked who owned it, us or Pace itself, or, but we have it. Is that correct? Okay. Thank you all. Appreciate it. Thank you.
Councilman Thornton?
On the audit, are you talking about the health audit for the health department? Is that what?
Are you referring to the
you all were
one
talking to?
Counselor Watts was asking for?
Mhm.
For the PACE program?
Just the PACE program?
Yes, sir.
Okay, then is the health audit complete for 2014 or 2013?
We had our survey in April, I believe, and we have a report, and then we have a corrective action plan, which is what you do. Actually, if you'll recall, I showed a video publicizing the response of the auditors on that.
That was the PACE program.
No, that was for the health system,
That was
the
for
Cherokee
the whole
Nation
health
Health System. Yes.
Then there is an audit preceding year for the PACE program?
They hadn't been audited, I believe they said, in 5 or 6 years. It had been some time. Don't hold me to that, but I know it had been some time.
But that's still being, this isn't completed yet, is what I know.
They submitted a corrective action plan, and we were on a conference call, the board members were, with CMS, going over that, and I will tell you, the CMS was very pleased with the corrective action plan.
Okay, on the staffing, excuse me. Of the new hospital that we're going to build, do you believe that you'll be able to staff that with specialists to operate on folks?
Well, absolutely.
Okay, we're 8 short now, doctors, but you think we won't have any problem staffing that?
No, I don't think so.
Okay. And when we do that, what's that going to do to contract health?
Well, again, contract health, we may increase our spending of contract health. When doctors are seeing more patients, they get referred out more often. And that was taken into consideration in our preliminary, our internal feasibility study.
Most of our contract health isn't it referred out to specialists that we have to do operate or something?
Right,
like
services that we don't provide as a direct service.
That will be in-house, a lot of it now?
We're doing, that's part of the feasibility that's being conducted by the Camden Group right now. So we're evaluating cardiology, we're evaluating cancer, orthopedics. Those are our high dollar expenditures in contract health. So we're looking to see, can we afford to do that within our own health system? And so as soon as that report's completed, then we can make a good
That give us the
recommendation.
opportunity to have more of our people seen by the Cherokee Nation than contracted out to someone else?
Clearly, we would want to do that, but you have to keep in mind, half of our patients are uninsured. So financially, we may not be able to do it all. We just can't afford to do it all. But that's one of the things we're looking at through the feasibility is how can we make it work?
I'd like for you to speak to that, on that the next meeting, see how we can make it.
I will make every effort. Like I said, we're still waiting for a final report from Camden. I think we have a call with them, I want to say the 29th of this month, to go over where they are. So hopefully I can at least give you where they are on that.
Okay, thank you.
Okay?
Counselor Buzzard, you're next.
Yes, Connie, I sent you an email about getting a patient transport. Did you get that? I hadn't had a
Patient transport?
response from you. It was a patient that needed an ambulance to transport him from his home to our clinic or to transport him to a healthcare facility up in Ottawa County. You may have not have gotten.
I don't remember that one. I've received 2 or 3 from you recently, but I don't recall that particular one.
I didn't see it, so you may not have got it. I'll check it out
Okay.
and send it back to you tonight. But is there a policy on the, how to ask the question, is there a policy on home visits from our clinics? I guess that'd be the question. Does doctors go out to a home to see a patient? And this particular patient I'm talking about, if he can't travel, he almost has to travel by ambulance, and that's what the email was about. I bet you hadn't.
I don't think I've seen that. It's unusual for a provider to go out to a patient home. There are some home healths that do provide that on occasion, but it's also very rare.
I'll send that to you, because there was
Okay.
2 or 3 documents with it, and I should have called you, I guess, I didn't do it. I will send it back to you
Okay.
tonight, because it's kind of a pressing issue.
Okay, it sounds like it is.
Thank you, Madam Chair.
Counselor Taylor?
Yes, I just had a question on the immunizations. It's on page 18 of our report. And under the Bonita Clinic, there are some asterisks by their immunizations. And there's nothing to refer those asterisks to.
I'm going to check on that.
Oh, good.
I'm sorry, I should have called. Why that clinic reports that solely, I don't know, but the asterisks just reflect that some patients refuse the vaccinations, and I'll try to get specific to that. But, the first asterisk, I think, is for the youngest age group, 1 patient declined. The second group, 4 patients declined, and on the vaccine, I think it was around 140 patients declined. The public health nurses report those, and they just wanted that reflected. That's why the percentage of people vaccinated was low, because a fair number of people declined the vaccination.
Okay, well, there's just nothing to, I mean, there's no asterisk anywhere showing what these asterisks indicate.
And I'm sorry for that, but that's what it is.
All right, thank you. Thank you, Madam Speaker.
Counselor Hargis is next.
Connie, I just wanted to say thank you. We seem to be getting a better response from Palladian, and I'm getting less complaints anyway.
Oh,
so
thank God.
I think they're doing a better job, and hopefully we'll get all the kinks worked out soon.
I can tell you that Dr. Montgomery, Dr. Stillberg, and Brett Hayes have been on, it's not even so much Palladian as it is a particular vendor. They did ran some numbers. I think they reported to me last week that we've seen or sent almost 7,000 patients or made 7,000 referrals thereabout. And about 18% of those have been denied. And of those, about 90% are with one particular vendor, which we expected was being a problem. Have met with them, set our expectations out, and just this morning, we got another complaint on that vendor with what they're telling our patients. They're being pretty ugly, so we may be looking at terminating any further referrals to that vendor because they're putting the patients in the middle of care, and all these other vendors can manage to do it, and there's no reason to put our patients in a position like that.
I appreciate y'all's efforts.
Oh, I appreciate the comment.
Counselor Keener?
Thank you, Madam Chair. Connie, good report. On page 20, we've just been about a month and a half on CHS changes for the 3 counties. And on the total cost of referrals, it's slightly outpacing the cost of approved referrals. I guess that the cost of denied referrals is that gap there. Is that right? Am I reading that correctly?
I believe so.
Okay, so your reports, I believe it says 96%.
Yes.
Somewhere, 96.1%, something like that. So that's a good start, I would say.
I'm glad you brought that up. That was still part of the report I wanted to get to, that we,
Okay, go ahead.
in the month of June, which is when we assumed those other counties, Craig, Washington, and 96.1%. And so those groups, those counties are included in that approval rating. We also have met in our meeting with Claremore, Hillcrest and Claremore, Bailey Medical Center in Owasso, and we met with Craig General, I think it was last month, after I broke my leg, as a matter of fact, those patients want to go there and try to keep them in their own communities and help those facilities as well. And I know Councilor Lay has asked, and we've met with Jane Phillips, and we're going to try to coordinate another meeting with them to see if they would be willing to see our patients as well.
Was that all you were saying? Because I have some more questions.
Go right ahead.
Okay.
Doesn't seem to be going. That's the way it seems to be going. Or, I mean, I'm not the chair.
So in your report, that's why you say to keep them out of Tulsa, just to keep them in their own areas.
Yes.
But you're not adverse to sending them to Tulsa, certainly.
Oh, absolutely not.
Yeah, I didn't take it as that. And then where are we with the percentage-wise, maybe, with the cost for the staff and equipment for the clinics? We're not going to get any help. How much more do you think we need, or where are we? Either way, you can answer that either way.
Well, I think the overall equipment budget, and I don't know by facility, just I could go pull it up, but the overall equipment budget for the clinics is going to be around $15 million. For that's furniture. It's the IT, which is I think around $5 million of that, and it's mammography, it's radiology equipment.
You still need a little bit more to fund that, right?
Probably.
I don't know what the percentage is. I know we're not going to make it right now if we had to open it.
We have some plans, but I think we're going to be okay.
Yeah, okay. And then also, I had one more question. Oh, are we buying, have we bought any property by the Hastings Hospital? Okay. There was a report that we bought Clinic in the Woods.
We have not purchased that.
That's just a rumor?
Just a rumor.
Okay, all right. Thank you.
We would like to, but it's just a rumor.
Thank you, Madam Chair. Councilor
Lay.
Thank you, Madam Chairman. First of all, thank you for that contract health work up north from you and your staff, Dr. Grimm and Montgomery, and everybody that worked on that. That's a big load off of us on the north end, off of everybody. So thank you all. Those joint ventures, we had none until all of a sudden a couple of weeks ago, there came this rumor, I guess, they may have some, and all of a sudden we got one. And so I think you can only get one of those things at a time. So I'm not sure about that, but I appreciate somebody jumped on it with both feet, and we're going to try to get that joint venture for the hospital, because that's the big expense. That's the big dog in the hunt there.
Yes, it is.
I appreciate you all working on that and getting on it so quickly, because I've got my ear to the ground too, and I didn't hear about it. You probably heard about it before I did, but it's going to be a big help to us. And you guys are doing a lot of good work, and I'm really, sometimes I get frustrated with the little things and call you, and I'm glad Frankie's getting some palladium calls too. So. Thanks for working on it. Appreciate it.
Councilor Vasquez.
Yes, thank you, Chairman. Connie, I just had a quick question back on Bonita. When we met with Craig General, do you have any feel for how long it might be before we would hear if they are open to, we're open to a relationship with sending referrals from our clinic to Bonita Hospital?
I believe we've began that already. I heard Dr. Stillberg talking about sending some cataract surgery there, I believe a little over a week ago. But, and right now, I don't recall the lady's name. One of the ladies in the meeting, we're trying to coordinate and set up the routine meetings for every other month to discuss opportunities.
I just hadn't heard anything after that, and I was just curious. Thank you.
Any other questions? Thank you for that great report. Before she steps down, I want to remind everybody, be sure and come to the grand opening of the new remodeled Redbird Smith original building. I've been out there several times. It's magnificent. It's first class. The artwork is beautiful. It's just top-notch facility and great dental department, and everybody come.
We're running the shuttle down there.
No, I don't know that we're running the shuttle down there that day, but. Okay, moving on to old business. I see we have none pending, and a new business.
Art has a question.
When is this rental?
Wednesday, the 13th, 2 days from now, 2 p.m. We'll have some refreshments and give you a personal tour of the building, and we've got several outstanding pieces of art, but there's one thing down there that just pops that everybody just loves, and they call it a wall covering. I call it a mural, but it was a painting originally by Daniel Horsechief, and I sit by him in church every Sunday, and it's gigantic. It's just out of this world. It's something. You'll want to have your picture made in front of it. Okay, moving on to new business. We have this resolution here for the joint council. We want to move it on to the council meeting tonight for a joint venture, and I'll turn that over to Speaker Jordan.
Yes, I would ask Dr. Grimm and Connie to come back up in case we have some questions about this. This is a resolution approving and authorizing the submittal of a request to the Indian Health Services to participate in the 2014 IHS Joint Venture Construction Program Agreement for construction and operation of the Tahlequah Hospital. I would put that in the form of a motion.
Second.
And ask to make comments. Would it be all right?
Yes.
Continue on. With that motion and second, I would let the committee know that as of July 1, after a long drought of no joint ventures, no hope of joint ventures, there is a slight opening as of July 1, the possibility that some tribes may be able to get a joint venture. And we want to be first in line if possible. And it worked out really well because we have not broke ground yet on Hastings Hospital. And the possibility, I think, as Mr. Lay said, there was probably only going to be one opportunity to get this before the government, and what a wonderful opportunity that it comes for the hospital. Because if we're successful in getting this joint venture with the hospital, it will alleviate all sorts of stress on the new and improved clinical system that we have envisioned for Cherokee Nation. I'm just real excited to be part of this. I want to commend Dr. Grimm especially for his long, hard work in Washington. He's also, I want to toot his horn a little bit, he slid on the committee that makes some of these decisions. So it works out real good for us, and I encourage each and every one of you all to approve this resolution and that we move it to full council tonight so that we have a total package going in, and maybe we're the first at the doorstep, and maybe get it approved quickly. So
we have a motion and a second, and we'll have comments, discussion. Councilor Watts?
Thank you. I'd like to be added as a sponsor, please.
Yes. Everybody want to be a sponsor? Any that doesn't? Okay. Shall we add everybody to be a sponsor?
And I did have a question.
Yes, go ahead.
It's been a while since we've had a joint venture. I think Ms. Skogie and Vanita were our last joint ventures. So would you remind me in terms of what joint ventures typically look like on cost sharing or payback, and just overall generally what they look like?
When the joint venture program first started, it was primarily the tribe paid for the facility. The agency came up with equipment, staffing, and operations dollars. Over the years, the Congress, in talking with the agency, said that if a tribe would pay for the equipment, they should give them extra credit on the scoring. And so it has become essentially a requirement almost, if you want to be considered to pay for both the construction and the equipment, The agency funds the staffing and operations above what you currently receive. So we would go through the program justification document process, the program of requirement process with them, and work out what our additional staffing requirements would be in operational dollars. And then whenever they figure what that is at 100%, they cut it by 15% and give you 85% of all that. That's just the rule.
Which is better than a kicking.
It will mean millions and millions of dollars, and was pointed out by the speaker. Just getting that for the hospital will relieve any stress on the remainder of the health system with all of our expansions that we're doing too.
Okay, so so when we started this process, there was a resolution for 70 million, if I recall right, that the council passed, and then there was a news release that went to 100 million or 80 to 100 million. I can't even remember if we know what the total cost of the whole package, but none of that was all construction. There wasn't any staffing, there wasn't any new equipment. So, and the only thing that we're going to be able to do possibly for a joint venture would be the Hastings Surgical Hospital addition. So do we have a full look yet on all the full scope of all this build out, what it looks like for not just the Hastings Surgical Hospital, but all of it? Do we have a plan for the healthcare build out on terms of new equipment and staffing it?
We do have a plan for the current hospital, yes. The current hospital plan. I'm making sure I answer your question.
The 100 million, quote, $100 million healthcare build out that keeps getting touted in the news, which is all these facilities. Do we have a staffing and equipment plan yet for all those facilities?
Yes.
Could you email that to us? I don't think we've gotten that by email, have we?
I will ask for it to be sent.
Okay, thank you. Thank you very much. Thanks for the hard work. Thank you, Madam Chair.
Any other comments?
Dr. Graham, Connie, job well done, Dr. McGovern.
Thank you.
What's the timeline on going to approved or when we all this?
If you'd like, we can also send to Gail to have sent out to all of you. There's a time frame that's in the application package. The due date to get everything in is September 12th, and then there's like about 12 other deadline dates that are listed in there. And so somewhere about the third or fourth deadline date, which I can't remember off the top of my head, they notify you that you've been awarded. And then there's all these other where you have to do the program justification, the program of requirements, work with the agency to determine, the size and the staffing and things like that. Until you get everything signed, then you can break ground. So we can get those timeframes out to you all in the way of an email.
Thank you.
Councilor Coates?
Yes, thank you. I'm trying to recall, and I may be wrong, but I think that we got a report a couple of months ago that was giving the groundbreaking dates on all of the various, and if I recall, I think it was January of 2014 was for Hastings, was that right?
We haven't set groundbreaking dates. We've set anticipated dates of completion of projects because we don't know what the weather's going to be.
Right.
And I know in the project report I handed you today, I noted that they had put September of this year for completion of the annex at Redbird Smith, and I'm already being told it's probably going to be November, so those are optimistic.
Well, that's why January stuck in my head, because I thought, well, that's an interesting time of year to do a groundbreaking, but anyways. So I don't know, but I guess my thought process was, okay, so we've got a September something deadline, and then there are several different deadlines that we move through before that, before we know if we're approved for the joint venture or not. What are we going to move forward in the interim anyway, or are we waiting until we know that we're approved, or what happens if we're not approved for the joint venture? I guess these are some of my questions.
The construction plans will be 100% complete at the end of this month. And so we'll have them ready to go and be ready to move once we know.
So we're going forward with it, whether we have the joint venture with IHS or not?
Yes.
Is the bottom line.
But we're holding up until we think these applications and see if we get it, because it would help immensely.
Would help
Makes
immensely.
sense.
Yes, it would.
And in regards to a groundbreaking too, the agency has said you can do a ceremonial groundbreaking at whatever point you so desire, you know, if you plan to move forward no matter what. But we just can't issue any construction documents. If we issue a construction document, that invalidates or disqualifies us.
I see. Okay. Thank you. Thank you.
Okay, any other comments, questions? If not, we need to move on for a vote. All in favor, let it be known by saying aye.
Aye.
Any opposed? All right, this
Thank you.
carries.
Thank you all very, very much.
And that will be the move to full council tonight?
Yes.
Yeah.
We have any other new business? No. Announcements. The next meeting is tentatively scheduled for Monday, September the 15th at 1 p.m. I call for a motion to adjourn.
So moved.
All in favor of adjournment, let it be known by saying aye. Aye. We are adjourned. Thank you, everyone.
10 minutes?